just making sure the mouse works.
Hi, good morning. We have no relevant disclosures, but would like to acknowledge the Medtronic Minimally Invasive Therapies Group for supporting the data source and analysis. The benefits of laparoscopic colorectal surgery are well reported. After the first case in 1991 and initial uptake, there were oncologic concerns, though, from reports of peritoneal seeding and port site metastases, which limited expansion of laparoscopy for colon cancer. Subsequent controlled studies in the early 2000s demonstrated the oncologic equivalence of laparoscopic to open approaches for colon cancer, giving the green light to expand the technique. Despite the safety and efficacy that was proven, the rates of laparoscopy for colon cancer remain low. In the years after the CAUSE trial, utilization did not jump as expected, and currently, rates are approximately 50%. Given the known benefits, investigating the root causes of underutilization and looking at methods to increase use of laparoscopy are warranted. Our goal in this study was to develop a predictive model of the patient, provider, and procedural factors that impact use of laparoscopic colorectal surgery for colon cancer. Our working hypothesis was that recognizing and addressing these variables could increase use of laparoscopy with their associated clinical and financial benefits. To this end, we performed a review of the premier inpatient database for colectomies performed for colon cancer between 2009 and 2014. Colon cancers were identified by ICD-9 diagnosis codes, then stratified into laparoscopic or open approaches based on ICD-9 procedure codes. We evaluated the patient demographic, hospital, and surgeon characteristics across groups, including age, gender, race, procedure year, payer status, comorbidities, hospital region and volume, surgeon specialty and volume, urban versus rural location, and teaching versus non-teaching status. For statistical analysis, we used a univariate analysis to compare the laparoscopic and open groups, with student t-test and chi-square statistics for the continuous and categorical variables respectively. Then, a regression model was constructed, using all significant predictors from the univariate model, and adjusted for patient, provider, and hospital characteristics. Adjusted to odd ratios were reported for all of the predictors included in the model. During the study period, a total of 65,513 patients with colon cancer were identified. After exclusions from metastatic disease, non-resection admissions, emergent cases, and robotic cases, a total of 24,245 patients were included in the analysis. 52% underwent a laparoscopic resection and 48% in open resection. Before adjustment, there were significant differences in age, comorbidity, obesity, and payer across the laparoscopic and open cohorts. Over the study period, there were also small but significant increases in laparoscopy, with a fall in 2014, and a concomitant drop and increase in open cases during the same time frame. There were regional differences in approach. The South region had the largest overall volume of colon cancer resections, but the greatest amount of laparoscopy was performed in the Northeast, and the lowest amount in the Midwest. General surgeons perform the majority of all colon cancer resections, but perform more through an open than a laparoscopic approach, while colorectal surgeons who perform less than colorectal surgeons approach cases more through a laparoscopic than an open approach. Both higher volume surgeons and higher volume hospitals were more likely to perform a laparoscopic colectomy than lower volume providers. In this sample size, all differences were statistically significant. Using the adjusted multivariate model, we found that the independent predictors of laparoscopy included more recent cases, privately insured patients, higher volume surgeons, and and colorectal surgeons. We also found that patients were more likely to receive a laparoscopic resection at an urban, non-teaching facility in the Northeast or Western regions of the United States, and in large volume hospitals having more than 500 beds. We do recognize limitations in the study. It was a retrospective review using an administrative data source. So there's inherent limitations from the study design and possibility of coding errors, but in such a large sample size, we would assume the impact to be minimized. There's also limits in generalizability, as not all hospitals report into Premier, and it only contains information from U.S. hospitals. Regardless, we thought it was a good start to pinpoint issues that can be addressed. In order to address these issues, we recommend increasing training opportunities, altering regional hiring practices, and developing regionalization or centers of excellence for colon cancer care. In conclusion, we found that there are independent patient, provider, and hospital characteristics that can be identified to predict who's going to undergo a laparoscopic resection for colon cancer. With these in mind, we can develop methods to increase the overall use of laparoscopy for resectable colon cancer, realizing greater clinical and financial benefits by shifting from open to MIS. Thank you.